Good afternoon, everyone. I've got folks starting to join. We'll be starting in about a minute. Okay, good afternoon to everyone and an early happy Thanksgiving. So grateful for all of you to join us for the second in our regional disaster health response system lecture series focused on support and management of children with acute respiratory illness. We're extraordinarily excited for today's session on high flow nasal cannula therapy for bronchiolitis and specifically focusing on how to manage pediatric high flow nasal cannula outside the intensive care unit. We've got three phenomenal speakers and I think a very good session for everyone. Next slide, please. So my name is Paul Bittinger. I lead the Region 1 RDHRS, and I'm joined by, as I said, three phenomenal speakers. We have Nicole Gizzi, who is here with us. She is a respiratory care clinical educator at Yale New Haven Children's Hospital. She has been a registered respiratory therapist for 11 years and has a master's in educational leadership. She's currently working as the clinical educator of the Yale New Haven Hospital Respiratory Care Department, and she's a coordinator for their ECMO specialist team. Nicole is also an adjunct clinical instructor for the University of Hartford's respiratory care program. We have Dr. Nader Ijaz. Dr. Ijaz is an instructor in pediatric critical care medicine at the Yale New Haven Children's Hospital and is a postdoctoral research fellow at the National Clinician Scholars Program at Yale University. He investigates the implementation of non-invasive respiratory support strategies in resource-diverse settings. And we are also thrilled to have Donna Wild with us. Donna has been a nurse at Yale for 19 years. She spent her first year working on a 28-bed pediatric floor, but the subsequent 18 years working in the pediatric ICU. She currently is serving as a full-time pediatric ICU nursing professional development specialist at Yale and holds BSN and CCRN certifications at Yale. Really grateful for all the support from the Yale New Haven Children's Hospital for this lecture series. As a reminder, the RDHRS is a funded program by the Health and Human Services Administration for Strategic Preparedness and Response, ASPR, and is designed to help support the New England community, all 6 states, in their efforts to improve their disaster planning and response. This particular lecture series, which started last week, is designed to help frontline clinicians in their management of children with acute respiratory illness in this extraordinary time of surge with RSV, with flu coming, and the other respiratory viruses that we are currently seeing. We very much appreciate the challenges that our nursing, physician, respiratory therapy, and other provider colleagues are facing across New England. And this lecture series is designed to be a very practical set of educational materials to help all of you in your extraordinary work through this surge. And we're very grateful for all the work that you're doing. Next slide. So this webinar is being, I can go back one. This webinar is being presented by the RDHRS, our program here in Region 1, which is the New England region. And our program is funded by ASPR, as mentioned. This program overall is a 6-week lecture series. So we'll be continuing for the next 4 Wednesdays after today at noon, the same time. Last week's lecture on the assessment and management initially of the child with acute respiratory illness has been archived and is viewable on our website at rdhrs.org. If you would like to let others know about today's session or the previous session, this session will also be archived and will be viewable going forward. So please let others know about this session if you'd like to share this content with them. Next slide. Do want to make some disclosures and disclaimers. The content that is being presented today reflects only the opinion and content from the individual speakers and does not in any way reflect the official policy or position of the United States government. And this is meant to be educational, but does not constitute medical device diagnosis or is not meant to specifically guide treatment. As always, licensed medical providers should follow their own judgment and best practice consistent with their training and circumstances. None of the information is meant to provide specific medical or legal advice. None of the speakers today has interests that they must disclose. Next slide. So we are going to get started right away with the content. So very grateful for our three speakers. I also do want to point out that there will be additional content this week. This week, we've got a bonus session, which is pretty extraordinary, from Michelle Gerson and the University of Vermont Critical Care Transport Program. Specifically, there is a brief additional lecture with a recording on it that will be posted on our website about EMS transport of the patient on high-flow nasal cannula. So for our EMS colleagues and for those who are working with transport programs, definitely want to refer you to that as well. So with that being said, let me turn it over to our speakers from Yale and thank them so much for their assistance today.
Thank you so much for that introduction, Paul. We're very happy to be here, and we hope that what we have to present today is helpful for everyone who's attending. So to start off, we did want to just list some learning objectives for the talk today. And a lot of this is review. We know that many of the individuals who are attending today's talk are familiar with high-flow nasal cannula and are familiar with its use in the pediatric population. But we're trying to give some practical tips for how to implement a program in settings that have diverse resources and may not have implemented this kind of technology for the management of respiratory illness in children before. So the learning objectives we're going to try to tackle are to review the role of high-flow nasal cannula in the management of bronchiolitis in particular, describe strategies for implementation of pediatric high-flow in non-ICU settings, focusing on the inpatient side, because as Paul said, there's another group that will be posting a series on the outpatient, the kind of EMS side. And then to review the use of clinical pathways from different institutions, both publicly available pathways and then our Yale pathway for high-flow nasal cannula initiation, escalation, and weaning in non-ICU settings as a model to kind of develop your own protocols and pathways at your institution, or to adapt these pathways as you see fit. So the outline for today's talk, we're hoping initially, Nicole is going to touch on some of the general principles of high-flow nasal cannula therapy, and then we'll go into its use in bronchiolitis and touch briefly on the evidence. And then very quickly go into implementation strategies, both at the systems and patient level, considerations that you might want to keep in mind, clinical tips and tricks, both from Donna and Nicole. And then I'll talk at the end about clinical pathways from different institutions, both where I have worked previously, as well as institutions that have publicly available pathways, and focus on adjunct therapies as well. So to contextualize this, as I think they did during last week's webinar as well, we are all aware of kind of the RSV surge that we've been seeing in across the nation, but in New England as well. This orange line is RSV, and you can see that over the past week or so, at least at Yale, we've seen slightly decreasing numbers, although we are definitely still in a surge, and we have no idea which way that trend's going to go. The gray line at the bottom is flu A, and we are starting to see a spike in flu A cases as well. So as we go into the winter season, we will likely see a double whammy, and we don't have an idea of where these other respiratory viruses are going to trend this year, given kind of the policies that have existed with COVID in the past. So this is kind of just to contextualize the talk for today. So to start off, Nicole is going to be talking about high-flow nasal cannula and some of the general principles of use.
Hi, everyone. I'm happy to be here and share some information with you guys. To start off, I'm sure everyone has used a high flow in some way, shape, or form. We're right now, for our volume, the best support we can give our bronchiolytics is by making sure that we're providing a nice humidified gas to their airways to help kind of reduce their work of breathing. The benefit of high flow really is that you can set the flow, really a range from a half liter all the way up to 30 in some of our pediatric cannulas, and provide a precise FiO2. And also we're going to be able to heat and humidify the airway and not dry it out like gas usually does without any sort of humidification. Next slide. So there's a bunch of different devices out, and your specific center might have either Fisher and Paykel or Hudson prongs, but the basic setup for these devices starts with the gas source, and the gas source is usually blended from room air to 100%. It then runs over a heater, gets humidified, goes through the circuit, and then is delivered to the patient through prongs. The best way to manage this device is to make sure that your prongs are the appropriate size and that you know how much flow the baby would get in terms of, their weight. So we can review a little bit of that. Next slide. So just the mechanism action for high flow. So your whole goal is to meet or exceed your patient's peak inspiratory flow demands. When you're able to provide flow at this high rate, you're able to help the airways get washed of their anatomical dead space. You can reduce the work of breathing. And also, when you're decreasing the work of breathing, you're, supporting the baby or the kid appropriately so that they're using less energy to breathe. The amount of flow that's administered through the cannulas can also reduce the airway resistance in the upper airway. And the whole goal of meeting their peak inspiratory flow demand with the flow is based off of what type of flow you're going to start with. Once you get to the point of being, greater than 2 liters per kilo on these patients, you're going to want to maybe think about using a more secure device that has a closed circuit like CPAP. But high flow is really a supportive therapy. So we're going to talk a little bit about how you can troubleshoot it and support these patients a little bit more effectively. Next slide, please. So for basic, when you're thinking about transitioning to high flow, for an infant, anything greater than 2 liters, a child, anything greater than 3, and a teen to a, smaller adult, anything greater than 6 liters, you're going to want to switch to the high flow cannula setup. The FiO2 range, again, is room air to 100%. And based on the cannula and which device you use, you can provide anywhere from 0.5 to 30 liters. And then on your larger size kids, you can think about using your more adult size cannulas. We often, rule of thumb and some literature supports that you're going to set the initial flow at 2 liters per kilo. When you're starting at 2 liters per kilo, you can think on a 5 kilo baby, that would be 10 liters of flow. On an adult, 10 liters of flow is not going to be a lot, but on this smaller kid with the right size prongs, this should be enough to wash out their anatomical dead space, provide their enough support for their inspiratory flow demands, and then in turn, decrease their work of breathing. Next slide, please. So some common pediatric devices that you can see throughout really, the United States and in Europe is the Fisher and Paykel OptiFlow. That starts with all of them basically start with a blender system, and then the flow goes over the heater and then gets provided to the patient through the cannula. You can see the Hudson Comfort Flow, which has the same principle. It's just the heater set up a little bit differently. And then the Vapotherm, which has precision flow, is more of a digital based setup where you're going to dial in everything through the digital box on the device in comparison to the other, which are passover devices. Next slide, please. Some of the troubleshooting when managing these devices is making sure that all of your connections are nice and tight and snug, making sure that you have enough water, sterile water for inhalation, and then working your way to the cannula and having the appropriate size cannula on the baby. When you are using the device that's on the left-hand side, you're going to be able to see your flow and FiO2 right on the blender. And then when you're using the device to the right, it's going to be a digital readout. Next slide. For troubleshooting with selecting the appropriate size prongs, you want to at least have a 50% occlusion of your nares to be able to provide enough flow to your baby or your child. One thing to keep in mind is that especially, and we just showed the F&P device for reference, all cannulas are going to have max flow ranges and low flow ranges. Make sure that you're staying within the right flow ranges because you will have some pressure release in the circuit. The Fisher and Paykel and some of the other devices, when you're securing it to their nose, you want to make sure that it's sitting on the face appropriately and that you have the right amount of space, at least around the nair, so that they're not fully occluded. Next slide, please. When you're securing the cannula, just make sure that you're using skin protectant. A lot prior to the new devices that we're using, we kind of were just tegaderming with a little bit of duoderm under the baby's cannula. These new devices that are out have wiggle pads or Velcro that makes it a lot easier when you're working on your troubleshooting, whether you're going to suction the baby's nose, you need to give a treatment, whether it's puffs, or really if you need to just readjust the prong size. This allows you to easily remove the Velcro and either change the cannula size or place it right back in the nairs. Next slide. Some of the other options you have, and these are things that you can use to kind of work in conjunction with the high flow. Albuterol or any type of bronchodilator therapy is not standard practice for bronchiolitis. However, some of our ex-premature babies, or really any of our asthmatics that have shown earlier on in life, have reactive airways disease. So you can treat that with bronchodilator therapy. We do have an option where you can run the nebulizer right in line. You can tee it in. If you've used any of the Aerogen devices or tee-in devices, you can provide the nebulizer right through the prong. Racemic epi, if you're trying to, some of the babies get some upper airway inflammation, so racemic epi can go a long way. And then you are able to give inhaled nitric oxide. So these are babies that obviously would come to a larger center that would be able to provide this, but you can tee in inhaled nitric and run it through a high flow or a regular nasal cannula for anyone that might need it. Next slide. I believe you're taking
Thanks,
over,
Nicole.
right? Yeah.
Yes, I am. Thank you. That was really, really helpful and great. So Nicole talked a lot about how high flow works and for what kind of advantages it offers over some other therapies. And I just wanted to touch on some considerations with high flow that might make it a less optimal therapy for certain patients. Like Nicole mentioned, being mindful of water in the circuit and the high humidification of these kinds of devices and how that might affect a particular patient is important. And importantly, if a patient is coming in apneic, blue, hypopneic, high flow is not going to help with that. So you really want to choose an advanced respiratory support methodology, consider preparing for intubation in those sorts of patients. As Donna will touch on later, gastric distension and poor feeding is often something that we see more with CPAP and BiPAP, but definitely a little bit with high flow as well. And we'll talk about feeding later on in the presentation. It's important to consider cost, especially if this is a new technology that you're implementing at your center. It does cost about 16 times as much as low flow nasal cannula per some cost effectiveness analyses. But it is cheaper than CPAP and BiPAP and often easier to kind of set up in the pediatric population. There is a very small risk of pneumothorax at very high flow rates, but the flow rates that we're going to talk about today are generally very safe in kids, and this complication is exceptionally rare in the high flow population. It's more common in the CPAP, BiPAP, and invasive mechanical ventilation population. And as I'll show on the next slide, studies do show that high flow nasal cannula reduces treatment failure compared to low flow nasal cannula, but it actually doesn't reduce intubation or mortality. So if you're thinking that a patient looks bad and needs respiratory support, starting high flow early might prevent you from having to start it later, but it might not prevent you from needing CPAP, BiPAP for the escalation of care. It might just be a temporizing measure to get to that point. And this is kind of a comparison of high flow nasal cannula and CPAP, which I think is a common question that people have. And what the literature shows is that high flow nasal cannula has a treatment failure that's about half compared to low flow, which is great. It's a great temporizing measure. And CPAP actually has a treatment failure that's half that of high flow. That doesn't mean that all patients should get CPAP and not high flow. It just means be mindful of the fact that if you have a patient on high flow who still doesn't look great, you should be thinking of escalating care and also potentially transferring the patient to an institution that can provide specialized pediatric care. We talked about gastric distension. High flow nasal cannula does tend to be more comfortable for patients and better tolerated. There are often issues with agitation regardless, which Donna will help us by kind of describing how she manages that from a nursing standpoint in her clinical practice later on in the presentation. There tends to be more water in the circuit in high flow because of the humidification and more skin breakdown around the nares from CPAP. And I talked about the pneumothorax risk and the cost as well. This is one meta-analysis that shows exactly what I described. You can see in the conclusions down here that there were no real differences found in intubation or mortality risk between high flow standard oxygen therapy and nasal CPAP in infants with bronchiolitis. But there was a decreased risk of treatment failure in the high flow group compared to the low flow group, and a decreased risk of treatment failure in the CPAP group compared to the high flow group, which just means that it may be less urgent to, if you have a patient on high flow, you may be able to temporize that patient for a period of time before escalating respiratory support. Next, we're going to talk about some of the implementation strategies that may be helpful in using high flow and implementing high flow in the pediatric population. And for the first kind of things to consider, staffing we know is a huge issue right now post-pandemic in many places, including at our own institution. And high flow is a technology, especially if it's something less familiar in terms of using it in the pediatric population, that may require some thoughtfulness around staffing ratios and the acuity of patients in any particular location. If there are patients being kind of cohorted into a unit, all of whom are on high flow, and Donna will kind of talk about how our nursing team thinks about that a little bit more. And then monitoring in terms of the continuous monitoring in patients once they are on high flow. Continuous pulse ox is definitely the standard, and cardiorespiratory monitoring is very helpful as well. And we'll talk about documentation and respiratory checks and how that might interact with the protocols you have at your institution later on in the presentation. But flow sheets and notes can be very helpful in documenting things so that during passovers from one team to another, people know kind of what trajectory the patient's been on and whether we've been escalating or de-escalating their high flow over the course of the past several hours. And Donna, do you want to talk a little bit about staffing and how we think about that?
Sure. So for us here at Yale, our staffing ratios on the floor, if you have kids on high flow, usually the staffing ratio is 3 patients to 1 nurse, and including in those 3 patients are usually 2 kids on high flow. Again, they're 2 liters per kilo. I believe the maximum amount allowed on the floor is 30 liters. We have had the ratios have been, tight with everyone, and we have had actually our managers and our educators and everyone involved in staffing. So we've had nights where I have come in at 12 at night because we didn't have staffing, or it's happening on all the floors where all of the managers, supervisors, educators were all being involved in staffing because the staffing is so tight. I know in the emergency room here, they have team nursing. I believe it's 2 nurses to 8 patients. And I don't think that there is a certain amount of high flow that they can have just because it's an emergency room and that's where they start the high flow. And I believe respiratory therapy, I'm not sure, Nick, how that goes for you guys, but I know you guys are also tight on staffing and you've been all over with our kids. But that's for nursing ratios. It's usually 3 to 1, and 2 of those patients are on high flow up until 30 liters when they'll be transferred to the ICU.
Thank you, Donna. Nicole, do you have anything to add from an RT standpoint in terms of RT ratios and how you guys think about that?
Yeah, for us, we have a pediatric team. So in a float team. So really what we try to do is divide the work up evenly. The high flows have definitely added a little bit strain on our therapists because it's considered a treatment for us. So when we're seeing these patients, we're seeing them every 2 hours. And also if they're getting therapy, we're spending the time with them. We really just look at the amount of patients and how many therapies they are going to need and just divide it evenly. Our volume in pediatrics has tripled in terms of our staffing numbers. We usually staff 1 therapist out on the PD floors, 2 in PICU, and 2 in newborn with a person floating to the ED. And we've been staffing anywhere from 8 to 10 therapists in those areas. So the volume has definitely increased pretty significantly.
Thanks. Yeah, and I added this line about champions and buy-in because in my experience, kind of implementing different programs at different institutions where it's a new technology or a new process, it really helps to have kind of an individual champion from each of these disciplines and potentially quality and safety as well, to be a consultant almost, even if they're not in-house. But if there's something regarding troubleshooting the actual device or the way it's being used for a particular patient or determining patient eligibility, even having somebody available by phone who can be consulted at a particular time to help the process move along, and also help with kind of unique challenges that they might be more familiar with just based on their experiences than the provider who's there in person, can be a helpful strategy to use. And then buy-in from all 3 kind of disciplines is very critical in achieving success in this kind of program. In terms of monitoring for bronchiolytic patients on high flow, the standard is to have continuous cardiopulmonary monitoring, including pulse oximetry. And for patients who look quite sick, even before you put them on high flow, you can certainly consider getting a venous blood gas or a capillary blood gas. But generally, your clinical decisions, unless they're quite hypercarbic, will be based on your clinical exam. And that's kind of how we do respiratory checks on patients and also titrate the level of flow, as well as decide whether or not we need to escalate from high flow to other therapies. Once the patient is off high flow, or if the patient never needed advanced respiratory support in the first place, actually data show that pulse oximetry can be intermittent for patients with mild bronchiolitis who do not require supplemental oxygen, because having continuous pulse oximetry has actually shown increased length of stay. So that's something to keep in mind as you're thinking about these patients. If they're looking better and you're able to wean them off high flow, at that point, once it's been 4 hours off high flow, you can consider transitioning to intermittent pulse oximetry. I do want to put in a plug for documentation, and everybody has kind of a different electronic medical record system, and potentially some paper systems out there as well. I do think having a standardized documentation for patients' respiratory assessments for bronchiolitis is very helpful, to have a shared mental model among teams for what constitutes a patient who's mild, moderate, or severe in their severity of disease. And for providers, having auto population of electronic notes can be helpful for implementing a new pathway. And by that, I mean, it could be helpful to have a drop-down kind of option for bronchiolitis that says, okay, if the patient's mild, moderate, or severe, what are the considerations and what additional steps in the pathway you might take that can help in clinical decision-making in real time. And that can, I think, apply for both physicians, nurses, and respiratory therapists in terms of their documentation and note writing for these patients. Donna's going to speak now a little bit about nursing tips that she has from her clinical practice on how to manage these patients.
So for most of these children that come in, they're going to come in usually with fevers, and they can actually look worse. A lot of our RTs are because children have fevers, they're breathing faster, they just like feel terrible and look terrible. So we want to aggressively treat our fevers. If they're greater than 6 months, you want to add a Motrin in with the Tylenol that you're giving every 4 hours. You want to make sure the room's not too hot, because some parents will say they're cold, but their child will be very febrile. And you want to make sure that the nurses are staying on top of giving that Tylenol every 4 to 6 hours. making sure that they're not missing doses, that they're not just forgetting to give Tylenol if they look a little better. Agitation is another thing that will come with the high flow and just feeling, terrible. Just like talk to the parents, let them know that agitation is completely normal. Even if they were at home, they would be crying, really fussy, kind of clingy. That is totally normal. High flow can cause the agitation to be worse just because the flow up their nose doesn't feel comfortable. Some distraction, if you have child life available, please utilize them. They can distract the child with toys. Ask the parents to maybe sit in their lap, play their favorite music or their favorite movie, whatever. And if you just can't seem to get the child to stop touching the cannula, pulling it off, screaming, crying, sometimes no-nos will just keep their arms straight. That's kind of a last resort. We don't really want to restrain our kids, but some parents are just not helpful. They won't hold their child. They're too afraid of the wires or the tubes. And sometimes putting a set of no-nos to keep the arms straight will allow them to get the therapy that they need, and they won't be pulling the cannula out and just making themselves overall worse. Next slide, please. Suctioning is big too. A lot of people are afraid to suction their babies. A bulb suction for just a nasal congestion, deep suctioning if they're not good coughers and they can't bring anything up, or even if a child is very young and they can't seem to bring it up, of course, they're going to swallow it and just sound overall worse. Patient positioning is huge. If you have a 4-year-old who has scooted down in the bed and they're kind of crunched and leaning over to the side, they're not going to breathe well. They're not going to get good aeration. So you want to make sure they're sitting up well, or, at least their head of bed is up, 20 to 30 degrees. You want to get them out of bed. If they can get up, get them up, let them play on a mat on the floor, sit them in a high chair if they're young enough. If their parents are at the bedside, maybe even sit them in a chair at the bedside, or even sit them on the side of the bed. Any kind of movement for these kids and positioning will help them improve a lot faster. Next slide, please. Obtain IV access. Patients get dehydrated very, very quickly with this. I think parents are a very good resource as to when their last wet diaper was, when their last feed was. A lot of times they just don't want to eat. They feel yucky. They don't want to drink. They don't want to eat. Some of them will come in dehydrated, and IV access is very large. If you go 24 hours without realizing they've had nothing to drink, then you run the risk of several attempts at trying to get IV access that you can't get because now they're very dehydrated. It's good if you have someone determine their 24-hour fluid requirements, like how much do they need in 24 hours? Are they meeting that? If it's something that they're not meeting during the day, can you give them IV fluids overnight to just help them get over this initial illness? Placing an NG tube can help, depending on the degree of respiratory distress and tachypnea. It might help with, especially with infants, after 2 liters per kilo, they breathe through their noses, right? So they're not only are they congested, but they feel yucky and they have this flow going up there. They're uncomfortable. They may not even want to suck a bottle or breastfeed. So you want to make sure you place an NG tube. Their belly might be distended. You can pull it for decompression, make sure the air is coming out, or potentially use it for feeds. You can feed them up into whatever you feel is comfortable for you, depending on their work of breathing, whether you want to feed them or not. Next slide.
Thanks so much, Donna. I think that was really, really helpful, and hopefully provided some tips and tricks for the bedside. So next, I'm going to be touching on the clinical pathways that I mentioned earlier. I want to, in particular, focus on 3 pathways. The pathway from the Children's Hospital of Philadelphia, where I actually trained as a resident and am quite familiar with the pathway as a result of that. The Yale protocol, which we're very familiar with at Yale, and Seattle Children's. Seattle's and CHOP's pathways are publicly available online. And so they might be good templates or models to use for how to escalate or wean therapy for these kids. The Yale protocol is unfortunately not available online, but I'll show some slides today. They're all similar in kind of their overall content, but have slightly different ways of tackling the same problems. And of course, along with these pathways, think about EMR integrated protocols, ways to make to create nudges for providers, nurses, and respiratory therapists to make it easy for them to implement these pathways, and then job aids for troubleshooting high flow nasal cannula, particularly just from a device standpoint. So this is what our Yale pathway looks like. It looks like a very busy slide, but just to give you a sense of kind of the decision-making points here, and I'll kind of simplify this on future slides. This is a CHOP pathway that I said is publicly available. It kind of divides patients into mild, moderate, and severe, and different approaches to each, which I'll go over as well. And the Seattle pathway, which is also publicly available in a PDF, and kind of breaks patients down into patients who have respiratory distress that improves with high flow versus respiratory distress that doesn't. And breaking it down kind of logically into a clinical decision-making kind of pathway in my mind, what I think about is, okay, first you're going to decide whether or not you need to use high flow in a patient. And perhaps another therapy is more appropriate, and that'll go down a different pathway that hopefully you guys will also talk about in future webinars. And I know you touched on a little bit during last week's webinar as well. We're going to focus on what to do if you do think your patient needs high flow today. And that includes deciding which equipment to use, how to choose an interface, what initial settings to choose for your patient, how to escalate or wean from there, including monitoring and assessments, and then adjunct therapies that you might use for these patients. And so to start off with the initial decision point of whether or not to even use high flow. So this is the Yale pathway. And here I want to highlight that at Yale, we kind of call it impending respiratory failure, which sounds very kind of very bad, which it is. But what I want to touch on here is that the elements of what we're calling impending respiratory failure are severe respiratory distress, progression to include hemodynamic instability, significant lethargy or altered mental status, and then worsening hypoxia or hypercapnia if you're choosing to do end-tidal monitoring or getting a blood gas. And the keys here are that you're looking at the patient's exam, so respiratory distress and mental status. Those are really the keys, and that's what's consistent across these three pathways that I'm going to talk about today. Bradycardia, hypotension, we rarely see, but those are patients that are very severe and likely will need more than high flow. And then worsening hypoxia and hypercapnia, you're only going to see hypercapnia if you get a blood gas, which I would recommend you do if you're concerned that the patient is in the severe category. If this is the case, the branch logic here is that that's when you start to consider stabilizing the airway and getting advanced respiratory support into the room, which can include high flow nasal cannula, but may also include CPAP, BiPAP, and intubation. And it kind of depends on how severe the patient is. But if that's not the case, then you're going to provide your kind of TLC, which they discussed during last week's webinar. Seattle Children's Pathway has a similar kind of branch logic here. And what their approach is for a patient who has severe respiratory distress, start low flow nasal cannula if they're hypoxemic below 92%. And they have a specific dose depending on the patient's age. And very quickly, and one of the keys I want to get across during this webinar today is that reassessments, frequent reassessments are key. Very quickly, within half an hour, if the patient's not improving on low flow nasal cannula, you go to high flow nasal cannula. And if there's concern for clinical deterioration, and that's what I mean when I say bradycardia, hypotension, et cetera, you're going to be escalating respiratory support beyond that very quickly. Don't wait to get high flow in the room. Really think about intubation or advanced respiratory, non-invasive respiratory support strategies. So when to use high flow, if I were to sum it up, is if you have a less than 2-year-old patient with bronchiolitis who has severe respiratory distress, and you feel that this patient, this particular patient with high flow could buy you more time, and that the patient might need non-invasive positive pressure support, but you're not sure yet, that's the kind of patient who's a good candidate for high flow. If you're sure the patient's going to need non-invasive or invasive positive pressure ventilation, I wouldn't really waste time with high flow. And if this patient doesn't look like they're in the severe category, you just focus on the TLC instead. When not to use high flow, like I mentioned, is if the patient's already apneic, gray or blue. If you think the patient might need high flow in the future, then just keep them on low flow, see what happens. Give them some time and be patient. Sometimes a low flow is enough and you're going to be able to wean from there. And consider comorbidities. There are patients who have, like was discussed earlier, are preemies, have heart disease, have asthma, and they might need other modalities that are more suited to their particular underlying problem. But often we see those patients disproportionately at centers like Yale, and they are less commonly seen in other places. So, but they're still there, and they might actually have undiagnosed underlying chronic medical conditions. So it's important to just keep in mind that if high flow is not working well for a particular patient that you thought it might work well for, that this might be the reason why, that there's comorbidities for which the physiology just doesn't work well with high flow. So the next kind of branch point is looking at the equipment. The devices Nicole went over earlier, and that kind of just depends on what your institution has available, and they're more or less similar in terms of how they provide high flow to a patient. And then the interface that Nicole talked about, what's important about that, and I'll highlight again, is that you really want the cannula to be covering about 50% of the nares, and not more than that, not less than that, because that provides kind of the optimal amount of flow for a particular patient. In terms of the initial settings, we'll talk about that next, and that's a common question that I receive in my practice. Seattle Children's takes an age-based approach, which some institutions do, and this is kind of their breakdown of that. So for kind of preemies up until 90 days of post-gestational corrected age, this is the floor maximum that they use is 4 liters per minute. And the minimum they use is 3 liters per minute. And by minimum, they mean that if you're below this minimum or at this minimum, you should be thinking of going to low flow nasal cannula as your next step if the patient's still hypoxemic, or if they're not hypoxemic, then you just go to room air. They have additional breakdowns stepwise to 6, 8, and 10 for these age groups respectively. And this is one strategy that you can use. A more common strategy in my experience, and the one we use at Yale, is a weight-based dose, which involves starting anywhere from 1 to 2 liters per kilo per minute of flow, depending on your institutional policy. In our experience, starting at kind of the highest flow of 2 liters per kilo per minute is often effective, because in the literature, actually, that has been shown to be more effective than 1 liters per kilo per minute, and equally effective with fewer side effects compared to 3 liters per kilo per minute. So that is one strategy. Some institutions like to start a little lower at 1 or 1.5. CHOP does 1.5, and then has the option of escalating to 2 liters per kilo per minute, leaving that as an additional strategy you can use if the patient's not improving. And in terms of FiO2, you can start, if you're starting a patient on a new therapy, I often start high. So I'll start anywhere from 60 to 100%, and then wean quickly, very, very quickly within minutes to what they actually need to maintain their SATs above 90%, is the goal in bronchiolitis. And so to summarize, it's generally safe to start anywhere from 1 to 2 liters per kilo per minute for children less than 3 years who have bronchiolitis. And studies have shown that 3 liters per kilo per minute causes more discomfort without improving outcomes. So if you're already at 2, consider what additional therapy you would choose if you, aside from high flow, if the patient's still not looking good after like half an hour to an hour on that level of high flow. And we talked about the FiO2, and ideally you want to titrate it so your FiO2 is below 40% if you are able to do that. Most pediatric protocols have a floor max of about 40 to 60% on high flow. And if you're having to need FiO2 above that, you're at a higher risk of needing escalation respiratory support. So you really want to be in a place that has specialized pediatric care and ICU capabilities if you're able to get your patient there quickly. In terms of the temperature you're setting your heater at, it's usually 30 to 37 degrees Celsius, just body temperature, which supplies the appropriate humidity needed for the patient. In terms of how to escalate or wean, these are the kind of the meat of the pathways that we're talking about here. The core of it is that you want to reassess within 30 minutes after starting high flow to see if your patient's improving. If they're not, high flow may not be enough, and it may not be the right modality for your patient. You want to continue assessments every hour initially while on high flow, and as they're improving, you can space these out to Q2 or Q4. And it helps to have a pathway, like I'll show on future slides, to guide how frequent assessments need to be. And it helps to have a respiratory score tool so that providers can use the same language around what constitutes a mild, moderate, or severe patient on high flow. This can guide whether or not you're escalating or weaning a particular patient at a particular time. And this is CHOP's respiratory score that they use, which includes how tachypnic the patient is, their work of breathing on exam, their mental status, oxygen requirement, suctioning requirement, including whether you need bulb or actual deep nasopharyngeal suctioning, like Donna mentioned earlier, how the breath sounds are, and whether there is a cough. And all of that kind of is constituted into a respiratory score that categorizes patients as mild, moderate, or severe. Other institutions have slightly different scores, which involve fewer parameters, and the main focus tends to be on tachypnea, work of breathing, and mental status as three primary parameters to look at. And in terms of escalation, so generally, we escalate up to a max of 2 liters per kilo per minute and an absolute max of 30 liters per minute in a stepwise fashion. But like I said, if you're really going above 2 liters per kilo per minute, you're going to see more side effects with gastric distension, and you might not get as much bang for your buck. So you should be thinking about other modalities at that point. Definitely, if you're at a place that doesn't have higher level of care, continue the process of transferring to higher levels of care as you are starting high flow and taking care of and stabilizing this patient, so that you can have peer support. In terms of weaning, we, for our pathway, generally assess readiness to wean every 4 hours. What we mean by that is a patient's deemed ready after 4 hours of stability or improvement on current settings, and can wean both flow and FiO2 in a stepwise fashion. Once you're at about 0.5 and an FiO2 of less than 40%, that's when you can start to attempt to wean off high flow to either low flow or room air, depending on the FiO2 requirement. And this is CHOP's, this is something that's available on CHOP's website publicly. And I think it does a good job of showing how a patient might progress through their pathway, and also similarly through Yale's pathway and Seattle's pathway. And the idea here is that on this top row, you have patient assessments. You have the dose of high flow that the patient's getting in the second row. This is a monitoring that the patient's requiring in the third row, and interventions that the patient might require if the intervention was due to an escalation of care. And you can see that the nice thing that this demonstrates, I think, is that the patient is improving. So this is the top row here before the pathway, that protocol that they're using is changing. So there's a lag time allowing for the patient to have hours of stability on the setting they're currently at before weaning, which is important because sometimes patients might have a good moment or an hour or so, but then they become febrile, they become agitated and need suctioning and look a lot worse. And it's important to allow for that period of stability before weaning, as this group did, from 1.5 to 1 liters after 4 hours of kind of improved symptoms. And then again, weaned 4 hours after that to transition to a more moderate level of their pathway. And then once they were on their mild pathway off high flow, they were only spot checking pulse oximetry rather than doing continuous cardiorespiratory monitoring with continuous pulse oximetry. Lastly, I want to touch briefly on adjunct therapies, and some of the adjuncts that were discussed earlier. Inhaled bronchodilators can certainly be used with high flow. If you're concerned that your patient has an element of bronchospasm or asthma, and you hear wheezing on exam that you think is more than just the RSV, then you can certainly trial bronchodilators once and do a really quick pre-post exam to see, did it make a difference. If it didn't really reduce the wheezing, if it didn't improve the work of breathing, then it's probably not something you want to use for your patient, because especially in infants, it can have side effects of tachycardia, agitation, etc. But if it did improve, you can feel free to make it a kind of standing medication and dose accordingly. Suctioning, frequent suctioning at regular intervals is important. But like Donna mentioned earlier, it's important not to overdo the deep nasopharyngeal suctioning, especially if a patient has an intact cough and is coughing up secretions well, because this kind of suctioning can increase nasal edema, which can make it harder to suction as you go. And some of these patients are going to get sick and require more suctioning before they get better. And then I say all this is under special circumstances because, as was discussed during last week's webinar, steroids, antibiotics, racemic epi, none of these therapies are standard for bronchiolitis. But if you have a patient who has a reactive airway and has a history, or you feel is very atopic, you can certainly consider steroids as an adjunct to your bronchodilators If you've got a chest X-ray that shows a pneumonia, you can certainly consider antibiotics, and then racemic epi if you're concerned for more of a croupy picture in combination with kind of a bronchiolitis picture. And then, of course, with the flu A surge coming on, you can certainly think about, especially if it's within the first 48 hours of illness, using oseltamivir or an IV equivalent of this medication if it's available at your institution. And if the patient has an NG tube and they are not, requiring escalating respiratory support, not tachypnic beyond 60 breaths per minute, you can certainly consider giving oseltamivir via NG tube as well if they're not able to tolerate PO. And speaking of tolerating PO, feeding on high flow is actually one of the things that the AAP was able to give a recommendation on in their statement in 2014. And the emphasis here is on maintaining hydration for patients who cannot maintain hydration orally. So this may take the form of IV or NG hydration, and it depends on how, to the degree of distress the patient is in and how long they've been in that distress. So if you're escalating high flow and the patient's in severe respiratory distress, you definitely want to make the patient NPO and start IV fluids. And the patient may even need a bolus, as Donna described. These patients are often very dehydrated. And if they're stable or improving on high flow, that's when you should consider an NG tube placement and starting NG feeds. And you can consider PO feeding eventually with a nurse at the bedside if they are clinically improving. And that can occur on lower settings of high flow, below 1 liter per kilo per minute. So I hope that's helpful in terms of a summary of the key decision points. And just to summarize, I think the takeaway points from our presentation: high flow is a useful strategy in managing patients with severe bronchiolitis. And I hope some of the strategies that we presented were helpful in terms of ensuring safety and effectiveness in settings where high flow for pediatrics is not commonly done. Frequent reassessments really are key. If it's not working, try something different. Suction the patient, reposition, see if there's fever, see if there's agitation that you need to treat, or if you need a different respiratory modality altogether. And use your resources, both online resources like the ones I presented today, offline resources. If you have a champion who's kind of an expert on high flow implementation, that would be great. If not, very quickly think about transferring your patient to a higher level of care as soon as possible. And we're happy to, I know there's several questions in the chats, and I think Paul, you may have been. Yeah.
Absolutely. There are a bunch of questions, and thank you so much to all of you. You can just go one more slide as well, just so folks can see the survey. Just if folks can, if you're willing to scan the QR code, we really do want your feedback on this webinar and overall on what you'd like from us from the RDHRS going forward. Really want to say thank you to all three of you. Just with amazing content. I want to dive into the questions very quickly, but let me just mention one more time. This webinar is being recorded and will be archived later today. It's going to be posted on our website, rdhrs.org. Again, rdhrs.org. This webinar, last week's webinar, and all the future webinars are viewable at any time publicly for folks who would like to see the content. If you either came in late today or would like to see a previous one, or you want to send this to friends, please do feel free to share with your clinical colleagues. All right, lots of questions. I'm going to try and hit the big ones as quickly as I can. Let me start with Dr. Ijaz. Can you talk about intermittent cyanosis? One of our questioners said they've seen it in several patients where they have more retractions and look cyanotic, but the SATs don't change. And can you comment on that?
Yeah, that's an excellent question. If you have a pulse oximetry on the patient, the first thing I would say is if you really need to make sure you have a good waveform. Some of these patients may not have great perfusion. Some of them are just moving around a lot, and you have to make sure, especially for an infant, that the waveform is a very reliable one in terms of whether their SATs are dropping or not. If you do feel you have a reliable waveform and the SATs are not dropping, but the patient appears cyanotic, sometimes that can be due more to perioral cyanosis that may not translate to true cyanosis peripherally, and that's where you're measuring your pulse ox. So it's not something that you would necessarily manage by increasing your FiO2, but if it's intermittent, you might be thinking about suctioning or repositioning if there was something about the position of the patient at that time that resulted in kind of a more perioral cyanosis compared to kind of a whole body cyanosis. And then always keep your differential broad. If there is a concern for intermittent apnea or other kinds of things that might be going on with your patient, those are things to consider as well.
Excellent. Thank you very, very much. I'm going to try and combine two respiratory therapy questions, if I can, for you, Nicole. The first is if you're aware of or have any respiratory therapy staff competency examples that can be shared for respiratory therapists who are not as familiar with providing high flow nasal cannula for pediatric patients. And sort of a companion question on if folks don't have high flow nasal cannula, don't have pediatric CPAP, excuse me, different question. If they don't have pediatric CPAP, but use a cannula that is larger and occludes the nares, how much PEEP you're getting and what would be the disadvantages or the reasons not to consider that strategy?
Sure. So I think starting with the first question, there's some online resources from some of the companies on just the management of high flow nasal cannula. And if you have any of those devices, their reps are really great for providing a little extra education and some simulation with it. But then there's also, I don't know if everyone has the resource of using Elsevier skills, because there are some other skills in managing high flow and kind of going down that pathway of using those tools. I'm not sure if everyone can access those. And then in terms of that question about using a bigger cannula, so on the cannulas that are standard off the wall cannulas, first of all, they definitely have to be humidified with that cool humidification. So the bubble humidifier is fine. But if you fully occlude the nares, there's going to be a back pressure into the system, which is not going to allow the flow to push forward. So I wouldn't try to utilize that type of support for a patient, because you actually can cause more harm and actually not really have the kid see any sort of support. There are other high flow cannulas that are out in the market that do not require the heater and humidifier. They use bubble humidifiers, but I believe their max flow is up to 15 and they go right off of a standard cannula. So there are some less expensive options for centers that might not be able to purchase the devices to provide high flow.
Awesome. Thank you so very much. And I think we'll be able to get probably one more question in, Donna, if we can, for you. If you can talk about, again, how you look at team resource needs from the nursing perspective and just putting together the care team, especially for community hospitals that don't see pediatric patients as much, what you would recommend in terms of strategies for trying to figure out how to right-size the team. And then also, if you can comment one more time on vital signs and reassessment and just patient reassessment, looking for fatigue, looking for improvement from the nursing perspective.
Okay, sure. I hope I can help. With the, are you thinking of community hospitals? Is that what you're thinking of? Something smaller?
Yeah, I think this question was from the perspective of community hospitals.
Okay, on floors or EDs?
Floors, I believe.
Okay, so I think that when you have, I don't know how much they're seeing or how much volume they're seeing, but I think when you have a sicker child on your floor, especially in a community hospital, most of the nurses know that child is a lot sicker. So they tend to pay to kind of help you out. It has to kind of be a team effort. I know that they probably don't have the staffing that we have, or even like the backup help that we may have. But just making everybody aware of the floor situation, like, hey, I've got this patient, but this patient seems a little bit sicker. If you hear any alarms going off, if you have any, if you have a chance to peek in on my patient when I'm not there, that's, it's kind of got to be a team effort. As for,
and maybe can I ask you to just answer the question also for the EDs? I know a lot of the people watching are caring for these kids in their emergency departments and don't have a pediatric floor. If you could just say if anything is different in the emergency department setting.
Well, for our emergency department, we have what we call team nursing, which is, again, like you have a team effort. If you have, for us, it's two nurses to 8 patients, and of those 8 patients, they may all be on high flow. But there may be one specific one that looks especially sicker than most of them. That would be the one that they would actually check in on more frequently, maybe every half hour instead of every hour. I know on the floors it's a little harder to check in that frequently, depending on how your patient ratio is. But I feel like somebody who is teetering with maybe getting a little sicker or on a higher bit of flow, depending on what they're allowing in their units, you want to check on them at the very least I would say, I know it's impossible for them to check on them every hour, but at least every 2 hours. If they can have even one of their techs look in on the patient, and say, even the techs who have been there a while know, well, this patient looks a little sicker, even if they're not, even the techs can give the nurse a heads up, hey, maybe you should go check on your patient. They don't look great. If the family's feeding them, those are sometimes when they start to have a little difficulty, they struggle with feeding. So just be aware of when, just have the family call out and say, hey, I'm going to give them a bottle or whatever, just so that if they're going to struggle, it might be at that time.
Yeah.
What was the other part of the question? I'm sorry.
Well, yeah, sadly, I asked so many questions, we run out of time on this one. So I think we're actually going to stop the webinar here. For all of our attendees, please know that we are keeping track of these questions. We're going to try and put together some FAQ documents to post on our website, again, rdhrs.org, including the archives of this webinar, last week's webinar. For those that joined late, there is an additional bonus webinar going up today as well on the use of high-flow nasal cannula in the critical care setting, hosted by our colleagues from the University of Vermont's critical care transport team. So lots of resources going up today. We'll try and answer the questions we weren't able to answer in real time. I want to really thank all three of you again, our colleagues from the Yale New Haven Children's Hospital. Extraordinary talks, all three of you, really appreciate it. Please come back next week. We'll be doing another session on use of positive pressure ventilation, and it will be a nice adjunct, a nice complement to this lecture. More webinars occurring through the end of December, again, during this surge that we're seeing. So thank you to everyone for attending. Thank you to our wonderful speakers. I wish you all a very, very happy Thanksgiving and a good holiday season. Bye-bye.